Hi, good afternoon, everybody. We will wait for a couple of minutes more to let everybody join in. Thank you so much for your patience. Hi, good afternoon, everybody. We will wait for a couple of minutes.
I
I
think we
think
are
we are
waiting
waiting
for
for
a
a
few
few
more
more
people to
people to
join
join
in
in
who
who
had
had
registered.
registered.
So
So
another
another
four,
four,
5
five
minutes
minutes
and we
and we
shall
shall
begin
begin
then.
then.
म्यूट करना पड़ेगा, टर्न टोन करो, ऊपर से साइलेंट कर लो ये तो उसको बंद आप तुझे को बंद करो यहाँ से बंद करते आवाज़ ही नहीं आ रही खोलने तो आ जाएगा
All right, without any further delay, we shall begin. Hello and good afternoon, everyone. A very warm welcome to all. It's a pleasure to see such a strong representation from across the insurance, TPA, and healthcare provider ecosystem. Because today's topic sits right at the intersection of all the three. I am Nancy Luger, Senior Vice President at Prospera Global, and it gives me immense pleasure to welcome you all here. On behalf of Prospera Global, I'm delighted to invite you to today's webinar, Medical Second Opinion, Driving Clinical Accuracy and Cost Optimization. We truly appreciate your time and participation. In today's healthcare environment, we are witnessing a clear shift from a volume driven care to a value driven care. At the same time, rising medical costs, increasing complexities of treatments, and variations in clinical practices across geographies continue to challenge all stakeholders in the ecosystem. Which brings us to a very important question. Are we always making the most accurate and cost effective clinical decisions? This is where the medical second opinion plays a critical role. They help in enhancing clinical accuracy, supporting evidence based treatment decisions, avoiding unnecessary procedures or admissions, and driving sustainable cost optimization for both insurers and patients. From an industry and operational standpoint, second opinions are increasingly becoming essential and particularly in high-value treatments, surgical interventions, and complex of chronic conditions. They not only strengthen patients and claim validation, but also enable more informed and confident decision making across the care journey. At the same time, getting a second opinion is becoming much more easier than before. There's great digital tools, teleconsultations, access to experts is now quicker and more organized and is widely available. This naturally leads to some important considerations for all of us. When should a second opinion be triggered? How do we balance the turnaround time with the clinical depth? And how do we
Integrate it
integrate it
effectively
effectively
into
into
the
the
existing
existing
claims
claims
and
and
clinical
clinical
workflows.
workflows?
That is
That is
exactly
exactly
what
what
today's
today's
session
session
aims to
aims to
explore
explore
through
through
practical
practical
insights,
insights,
real
real
world
world
experiences,
experiences,
and
and
industry
industry
perspectives.
perspectives.
Before we
Before we
move on
move
to
on
the
to the
panel
panel
discussion,
discussion,
I'd
I'd
like to
like to
pass on
pass
the
on the
forum to
forum to
Ankit,
Ankit,
COO,
COO,
Prospera
Prospera
Global,
Global,
who
who
brings
brings
in
in
12
12
years
years
of
of
experience
experience
from the
from the
insurance
insurance
industry.
industry.
Having
Having
worked
worked
extensively
extensively
in
in
the
the
UAE
UAE
market
market
and
and
now
now
based
based
in
in
Europe,
Europe,
Ankit
Ankit
brings
brings
strong
strong
cross-market
cross-market
expertise
expertise
and
and
deep
deep
industry
industry
knowledge.
knowledge.
He
He
will
will
now
now
take you
take you
through the
through the
next
next
part of
part
the
of the
presentation.
presentation.
Ankit,
Ankit,
over to
over to
you.
you. He will now take you through the next part of the presentation. Ankit, over to you.
Ankit,
Ankit,
you're on
you're on
mute.
mute.
I'm so sorry. Now I'm audible. So sorry, guys. Yeah.
Yes,
Yes,
Thank
please.
you.
please.
Thank you, Nancy. Thank you for the introduction and a warm welcome to everybody joining us today. I will now walk you through second medical opinion, address some common misconceptions, and share how we at Prospera deliver real clinical and cost value through SMO. I will share my screen now, and I have few slides to present. Okay. Now, what is SMO and its purpose? I know everybody in the forum as well as the audience joining us, they have a basic idea of what SMO is, but it is not a very generic term which we use nowadays that, have a second medical opinion from a doctor. It's deeper than that. So what is SMO? SMO is an independent clinical review of patients' diagnosis and treatment plan by expert doctors. It is especially valuable for high risk or high cost procedures, ensuring the patient gets the most accurate and appropriate care recommendation. Now, what is the purpose of SMO? The purpose of SMO is to ensure that the proposed treatment is truly necessary and appropriate for the patient. It helps avoid unnecessary surgeries, improves clinical outcomes, and ultimately reduces cost and risk for both patients and the insurers. Now, why SMO matters? We gathered some data from some basic studies from all across the globe, and as you can see on the screen that we have some clinical impact. Some studies show that 88% cases show diagnosis refinement, that is diagnosis change. 40% cases have major clinical changes, including no surgery at all, which means that around 40% cases it can be avoided of major surgeries and can be managed through alternative medicine or probably alternative healthcare. So the clinical impact directly corresponds to the cost impact. Some studies reveal that there was a $15,000 average savings per patient, which costed up to $43,000, which is basically for oncology patients. There were $5,000 to $7,000 savings per patient in one of the studies, even in surgical pathways. This clearly shows that medicine is complex and there is a high variability in decisions. Now, let me just quickly talk about what is the current reality, what insurers as an industry we think about SMO. We say that we are already doing SMO, which means the case is sent to one doctor, opinion is received, and decision is taken. But the ground reality is single doctor opinion is not equal to true SMO. There are so many complex cases in oncology, ortho, spine, which cannot be validated by just one doctor or one clinician. And hence comes the risk. The risk becomes more and more, which means that it can be biased or subjective decision making, incomplete clinical assessment, and over-reliance on individual judgment. So we see now the gap and how we at Prospera delivers SMO to our clients. We know that there's a gap, which means that there is no standardized framework currently used. The insurance companies, they don't have a structured panel review. And of course, there is no audit trail or clinical governance. Now we come to the Prospera approach. At Prospera, we recognize that traditional SMO approaches are often fragmented and reliant on single opinion, which can lead to inconsistent and biased decisions. To address this, we have built a structured, panel-based SMO process that combines multi-specialist expertise, standardized clinical protocols, and a multi-level review framework. This ensures every case is evaluated thoroughly, transparently, and with strong clinical justification. Number one is panel-based review, which means we have a panel of at least 2 to 3 doctors of at least same specialty or super specialists if required. Case complexity determines the panel composition. We have multi-level decision framework, which means we have a 3-level approach. Level 1 is primary review, level 2 is panel consensus, and level 3 is escalation for complex high-level value cases. We have structured clinical protocol, which means we have a checklist, diagnosis validation, surgical necessity, and alternate treatment pathways. We also have a process of evidence-based outputs, which means that there is a clear recommendation by the doctors that either the surgery is required, avoided, or can be deferred. And if there is an alternate treatment plan required, we can bring that into the picture. And last but not the least, governance and transparency, which means audit-ready processes, reduced bias, and consistent decision-making across cases. With this, I come to the end of this presentation, and there's just one line I would like to add on before I conclude, which is a true SMO is not just one opinion, it is structured, multi-expert clinical validation framework. This comes to the conclusion of my presentation. Now, before I pass on the forum to Dr. Geeta and the panelists, I would like to introduce them. We have joining us today Dr. Kruti Shechachalam, the Head of Member Health Services, Life and Medical Claims from Secoon Insurance. She's a hybrid athlete with grit. She's a passionate Toastmaster with voice and stand-up comedy enthusiast who secretly takes pride in knowing how to land a punchline. She does it all with heart. We welcome you, Dr. Kruti. We are really honored to have you as a panelist.
Thank you so much.
Next we have Dr. Sheena, who is the Deputy Manager at NGI. With over 14 years of experience in the industry, she specializes in claims management and has extensive involvement in operational processes. Dr. Sheena brings valuable insights from a payer perspective, particularly in handling complex cases and improving claim efficiency. We are pleased to have you here, Dr. Sheena. Welcome on board.
Thank you, Ankit.
You're welcome. Next, we have from the hospital side, the provider side, we welcome Dr. Ravi Kumar TV, who is the HOD and Consultant, Department of Orthopedics from Ramaya Memorial Hospital. Dr. Ravi Kumar completed his graduation from Mysore Medical College and his post-graduation from KIMS, Bali. He further pursued specialized training in spine surgery, including the prestigious AO Spine Asia Pacific Fellowship in 2013. We truly welcome you, Dr. Ravi Kumar, and we are really excited to hear your views on the second medical opinion.
Okay, thank you.
Welcome. Last but not the least, we have our very own Dr. Geeta Sadana, the Director of Medical Claims Audit and Training here at Prospera Global. Dr. Geeta comes with more than 23 years of experience in the industry, with spending 14 years in UAE insurance market. She is known for a calm, nurturing personality and her ability to make people feel supported and at ease. She brings clarity and structure to the complex medical and insurance conversations. This brings to the end of my presentation. Thank you all for your time and attention. I will now hand it over to the panel for what I'm sure everybody is excited and for insightful discussion, and everybody's looking forward to. I'll stop my screen now, and Dr. Geeta, you can take over from here. Thank you, everyone.
Thank you, Ankit. Thank you so much for the introduction, and a very warm welcome to everyone joining us today. Okay, now let me start with a simple thought. Every day across healthcare system, thousands of treatment decisions are made. Some are routine, some are life-changing, and some that could go either way. The real question is, how do we make sure we are getting these decisions right? And that's where second medical opinions come in. What was once considered optional is now becoming essential, not just for the better patient outcomes, but for clarity, appropriateness, and cost efficiency. I'm truly delighted to be moderating today's session with our esteemed panelists, Dr. Kruti, Dr. Sheena, and Dr. Ravi. Yes, let's dive right in. The first question, which is revolving around the cost containment, is for you, Dr. Kruti. Yeah, from a leadership standpoint, how do you see medical second opinions contributing to cost containment across the claims portfolio? Have you observed any quantifiable reduction in the claim payouts or any avoidance of unnecessary procedures through second medical opinions?
Good afternoon, everyone. Second medical opinions date is back to the 1970s from the United States of America, who are the forerunners of health insurance. So that was when a panel of insurers saw that there's a lot of variance in the claim cost due to variance in clinical decision making. Second medical opinion for me has always had a very real measurable impact when it comes to cost optimization, claims utilization, and they act as a quality control mechanism across the entire portfolio. For me, someone who's been in this industry for 1.5 decades, I call it as a strategic lever uh, in how they help us to strengthen clinical governance, identify variance in provider behavior and trends towards abusive and inflated claims. And the most important elementary principle of second medical opinion is towards better patient outcome and a stronger peace of mind for our valued clientele. It has been known that there are certain elective cases which are invasive, especially coming from providers for exaggerated known trends and patterns. Definitely, we have seen that second medical opinion has strengthened clinical decision making and brought about a reduction in claims utilization and a combined viability in the policy performance across the entire portfolio, especially in cases which are elective and invasive with musculoskeletal system neurosurgical cases, elective spine cases, cancer cases, and with immunotherapy and autoimmune diseases being an epidemic over the last 5 years, and considering the kind of business that we are writing when it comes to high value immunotherapeutic drugs, both in autoimmune disorders and cancers, definitely second medical opinion has proven to strengthen how our claims are performing and also validate the loss ratio.
That's really insightful, Dr. Kruti. And yes, I agree with everything. This is how it's happening these days in the market. So, yes, now coming from strategy to execution, where decisions actually translate into outcomes. And we have got Dr. Sheena to throw light on that. So, Dr. Sheena, now from an operational perspective, how do second opinions support better claims validation and decision making at the time of adjudication? Have you also seen cases where it helped prevent overutilization or unnecessary admissions?
Yes. Good afternoon, everyone. Thank you for having me, Dr. Geeta, Ankit, Nancy, to be part of this very important discussion. Yes, definitely. Second medical opinions, as Dr. Kruti has already said, it's a very important clinical checkpoint because payers who have a very structured second medical opinion program, they consistently achieve at least 10 to 15 or maybe 25% reduction in their overall average claim cost. They improve the clinical adjudication by mainly by maintaining or strengthening the medical necessity validation. Now, as already mentioned, frequently encountered cases are high cost biologics. When there are instances when the radiology is over interpreted, and sometimes you find that the clinical symptoms and the requested procedure are not correlating. In such cases, a second medical opinion may recommend a lower line of therapy. This is usually true in the case of rheumatology cases. Mm-hmm. The second key benefit is a reduction in the high cost claims, high cost care, like a case of a CABG, coronary bypass graft conversion to a medical management. We have had cases where this was where a cabbage was recommended. However, a second opinion doctor, after a thorough evaluation, again came to the conclusion that that after an intravascular study, he recommended that the lumen was not narrow enough for a vascularization, for a revascularization, and the remaining vessels were not adequate for taking up for a graft, and hence only medical management was recommended. So in such cases, what happens is there is a reduction in the total high value claim. Or in the case of a long-term admission that was shortened for rehabilitation. This is most commonly seen in stroke cases. In a stroke case patient, after the preliminary management in a hospital, the most common reason for continuous hospital stay is for the rehabilitation, continued stay for physiotherapy. So in such cases, when the functional improvement has plateaued, the rehabilitation continues. And so this will lead to an increased claim cost. So in such cases, a second medical opinion, what do they do? A second medical opinion, a rehab specialist can confirm if no further inpatient gains can be expected and will recommend a transition to a home-based care. Thirdly, a strengthening of a fraud, waste, abuse detection. With NSMO, you can find a pattern of unnecessary admissions or inflated treatment plans, which becomes easier to flag for a team. And last but not the least, a defense of the audit department is also provided by a second medical opinion. There are instances when, of course, all from a payer's perspective, from the operations view, every high value case will be subject to an audit in most cases, either by a regulator or by an internal audit system. So having a strong second medical opinion as a backup, as a support, will always support the audit department, because will always support the claims department, because a second opinion documentation becomes a strong evidentiary support, especially useful in case of DRG challenges and medical necessity disputes. So what happens all here is there is a prevention of a high-cost surgical claim, a reduction in post-operative complication risk, a less future utilization in the form of readmissions, and less future rehabilitation procedures on post-operative visits.
Thank you, Dr. Sheena. This is really interesting to know, because very important point what you have discussed or what you have raised is about the cabbage, that the patient actually did not require that and could be managed conservatively. So just tell us, how did the patient found it? He would be definitely very happy that he has not been taken up for this high care surgery. Like, how was it?
Yes, you would be. Yes, even we were quite surprised, Dr. Geeta, because we were almost going to approve the case, but then of course it was subject to a second opinion, and the patient was also compliant to our need. And the doctor, in fact, he was from home country itself. So the doctor opined on seeing it that, like what I said, he did a repeat angiogram. And the repeat angiogram, he found that the lumen of the RCA lumen was not very much narrowed. The diameter of the RCA was not very much narrowed, number one. And secondly, he had comorbidities. So a high risk of comorbidities, including pulmonary edema, was diagnosed. So these comorbidities made him a high risk for taking up for a cabbage surgery. All right. And thirdly, those conditions, the other vessels were not formidable for taking up for a graft procedure. So these conditions, when coming from a second medical opinion doctor, convince the patient as well. Of course, any patient would try to avoid a surgery. They would be happy. So this patient continued on medical management. So because the patient was continuing to be insured with us, he did continue with medical management because he was a 60-year-old patient. So he was continuing on medical management and improvement and just treatment for his comorbidities. So that's
all right. Thank you, sir, Dr. Sheena. And now, this is where it really matters. Is the clinical frontline, where every decision directly impacts a patient's life. So it's for you, Dr. Ravi, as Dr. Kruti had mentioned.
Sorry to interrupt,
Yeah,
Dr.
so
Geeta. Dr. Ravi, can
yeah.
you also please switch on your camera because we can't see you, I think.
Yeah,
There's some issue. Yeah,
my
sure.
camera is not working for today. I
All
don't know,
right.
but
Okay.
I'm following you people. Don't worry.
No problem, Dr. Ravi. Yes, Dr. Geeta, please go ahead. Yeah.
Okay, so yes, Dr. Ravi, as Dr. Kruti had rightly mentioned, like elective spinal surgery cases are one of those cases where we do require a second medical opinion. So we would like to know from a clinical standpoint, how do you differentiate between a genuine surgical necessity and cases where conservative management still is appropriate?
Okay.
And from your experience, how often do you see that surgery is being advised prematurely? And then what should we look for actually? Like, what are the things that we should understand? It is the time for the surgery, or these things are not present. These symptoms are not there. These signs are not there. So this should be triggered for a second medical opinion. Could be the patient does not require a surgery.
Okay. So with your questions, there are three parts in this. How I perceive it, the one thing. Second thing is like how the early surgeries are like which can
Yeah.
be postponed. That's the second thing. And how I look into things, that also I'll be answering. So there are three parts in your question. So as such, like a true surgical necessity should be symptom driven, not based directly on imaging. Okay,
Mhm.
so a doctor who is going to treat the patient should examine, he should mention his clinical findings, and you need to correlate that with the MRI findings. Okay, so sometimes the patients will have an uh, arterial disease which will really be like a claudication related to a neurological condition as well. So whether those things they are really evaluated or not, they needs to be this one. So I see so many patients where they come with an MRI, but they all say that they have been advised for a surgery. But really, on looking at the MRI as well as looking at the patient's clinical conditions, most of the time, which can be avoided. That's what my experience is. Always, we need to follow the comprehensive clinical assessment. Wherever I see those patients who have been advised surgery, so the clinical assessment charts or necessities are not done properly. Okay, so they just suggest that they have been having some disc problem and they require surgery, but what are their findings in those scenarios? They are not mentioned in any of their case sheets or follow-ups. So that's one thing that I have been this one. Most of the time, the role of conservative management will never be given an option to the patients. Okay, so that's one of the things commonly come across. So the moment they say that a disc problem is there or a minor disc is there, all of them have been advised surgery, but which is not essentially true in real life. So I treat my patients, I always give them the first option as conservative management. If still they find that okay, the what I am telling is little odd from what the previous doctor has told, I tell them you go back to any surgeon who operates the spine on daily basis. Okay, not a regular orthopedician or a regular neurosurgeon who operates spine once in a while or who calls someone else to operate for him. So these scenarios commonly happen. So they are not the good clinical judges. They see an MRI with something and they ask the patient to come for a surgery directly, but they will not be operating. So hence most of the time clinical decision making should be based on the symptoms. So it should be symptom driven decision that we needs to be doing that. So another thing that I commonly come across is over reliance on the imaging. So
Doctor, sorry to interrupt you, but I have one question for you because we were discussing about the symptoms. So, what
yeah,
do you think, like the patient symptoms, the duration? Because many a times, like when we get a surgical this thing approval, what the doctor mentions over there is that member has been taking the treatment, let's say for 6 months, and of course there is no relief to it. So, do you think 6 months is an ample time, and now it means the patient should be considered for surgery?
yes, if that is the scenario, it is better to see whether he has really consumed those conservative
Okay,
management options in terms of medications, whether he has purchased them, he has taken
all
them,
right,
or
all
he
right,
has
okay,
opted for any other thing that we need to be like making sure, like
okay,
clinical history. Okay,
okay.
or is the symptoms worsening in the last 6 months? So that's also a factor
Okay.
which needs to be. The pain cannot be the same for 6 months. Okay, either it should decrease
Correct.
or it
Yes,
should
yeah.
increase. So whether he has received the treatment or not, one concern is always we need to put a point on that. Okay.
Mhm.
So next thing is there is an over reliance on the imaging things. Okay, so as I said, in clinical examination compared to what we have been taught, they are supposed to be the prime driving things for a surgical indications. Okay, so otherwise most of the time the MRI diagnosis will be over, like either it is on the higher side compared to the existing clinical scenario, because either the MRI, MRI reporting doctor may not have been given him proper details about the clinical scenario of the patient, what is his radiculopathy or what is his weakness in his limbs. Okay, so if those things are not given to the MRI people, they always try to put everything. L1, L2 is also having a disc bulge, L3, L4 is also.
Yeah.
So it becomes kind of this one. So we won't be able to treat them within really this one. So sometimes when there is multi-level disc problems are there, the obviously a newcomer or an over enthusiastic surgeon might always opt to fix them the entire level, which will increase definitely the surgical cost as well as burden to the patient. Okay, so that's one of the things that I come across, over reliance on the imaging. Another thing is in the present world, with the present competition levels, the importance of conservative care is never given to the patient. So that's one thing. And patient counseling and decision. So definitely, sometimes they scare the patient. So these things also are there. Having said this, as an spine doctor, I do somewhere around 400 surgeries in a year. So most of the time I treat them, I convince them not to go for surgery and tell them opt for a conservative management for some time. Anyway, we are not losing anything with epidural steroid or trigger point injections. And then if they really come back to me after certain days, so then I operate. So that's one thing that really is helping the present population. So they bring more patients to me with that because the doctor was not eager to operate on me. So that's how it is. Another thing, on the contrary to that, okay, so if I have said a minor disc bulge in an young lady who is 35-year-old who can be treated conservatively, and some of the patients will be restless, so they want an immediate quick relief from that. Okay, so they go to another doctor, they get the surgeries done. I feel surprised with that behavior of the patient side also. So in the present day, there are problems related to the MRI, the problems related to the overdiagnosis, or the problems related to the quick relief from the patient side also. So where the doctor will be in a confusion whether to opt for a surgical management or a conservative management. The moment you see or convince a patient for a conservative management, you are being in the present world, some of the patients, they look you down as you may not be confident in treating me or giving me a quick relief. So that's also one thing that we come across. Okay. So the third question that you are telling was about how the cost can be reduced. Definitely, whenever we treat patients, we definitely end up when they are treated conservatively, the cost will be usually reduced. So definitely, I will be uh, more dependent on clinical scenario, whether the previous doctor has given me or concluded, or whether I can concur whatever his findings he has been written, or whether he has not mentioned, or whether the MRI is overly relying on small disc bulges. Okay, so these are the things. Okay, and also the patient factors, from how long they have been. Okay, so a patient who's been visiting me for past 3 months definitely is a candidate for surgery. I do put some red flags. Okay, so whenever I convince them for surgery, for the insurance company, I give the details of all my 3 previous consultations, what was given and what the patient has come for. So those previous things, if they are proper, I should feel the patient should be eligible to go for the surgery.
Okay. Thank you. Thank you so much, Dr. Ravi. And it was really insightful. And what I summarize now is that it's not the it's the symptoms which we should rely on. Because many a
Symptoms,
times, yeah, that was
the
really
symptoms as well
insightful.
as the clinical documentations, like what
Yeah.
weakness is having, whether he's having foot drop or toe drop,
Okay.
what's his
Yeah.
incapacity, that we need to be documenting it. Okay, if that document is good, that should be the indicator for approving surgery.
All right. So from an insurance perspective, what I can see is that definitely it's our claims history. And of course, the history that we should always get from the providers that what all non like painkillers or physiotherapy has been tried by the patient. And then after that, a surgery, yes, can be considered.
Yeah, I just want
Okay.
to add one more
Yeah.
thing regarding the second medical opinion. So, in an emergency scenario, let's assume a patient with an infection or impending cardiac venous syndrome, who
Yeah.
is not in a position to go out of the hospital to go for a second opinion. I always give them the medical records of the patient and drop the patient for a daycare procedure or daycare
Yeah.
admission, and then take the reports to another doctor, take second opinion if they are in doubt. Okay, so that happens with me. I always demand for a
Yeah.
second opinion where there's an emergency scenario. I will not send the patient, but I'll ask the attenders to go take opinion from the this one. Okay, so
All
if the
right.
second
Okay.
doctor also gives a second is opinion about surgical requirement, then that report also I most of the time I put in my claim record.
Okay. All right. Thank you. Thank you so much, Dr. Ravi. Okay. And now, Dr. Kruti, coming over to you. Okay. Like, what are the key triggers or red flags do you believe should mandate a second opinion? Like, is it the high value claims or surgical recommendations? Or is it complex chronic conditions and the pharmacy, the immunomodulators, as you have said? So, what do you think are the red flags? And yes, it should be then, we have to send the patient for a SMO.
See, any trigger from an insurer's standpoint, across the fraternity, we have believed that any trigger works well if it is extremely clear, well defined, and rule based. So a trigger could either be a cost, because it could be either a cost, it could be a provider behavior, it could
Mhm.
be the clinical variance in decision making, or it could be a trigger from a member. So if I have to dissect it, coming to from a clinical variance point of view, definitely it is high value claims, which is in the form of cardiac, immunotherapy, cancer cases, neurosurgical cases, and where there is a difference and the variance is both in terms of clinical decision making and in the terms of financial. For example, going for a total abdominal hysterectomy in a case of a benign neoplasm without a trial of conservative management. Okay, for example, directly for a patient who's lifted weight in the gym, directly you go for a spinal cage with fusion without a trial of conservative management. Financial is either the forecasted claims could be something for a member who's come with a very acute presentation, which could either exhaust his limit, or catastrophic claims, which could inflate to up to around 150 to $200,000, which could wipe out the complete portfolio. The viability and the performance of the complete portfolio is definitely a red flag. Provider
Mhm.
behaviors, right? And I've always believed that data is king, and data is something which is more dominant than directives. So when you talk about, for example, from a provider point of view, so data which has always proven that there's a lot of wastage and abuse, certain
Mhm.
clinicians who directly go for surgical kind of management, increased trends of red flags of suspicious length and altered extended length of stays, repeated readmissions, high incidence of iatrogenic disorders or negligence. That is a trigger from a provider aspect. And from a member's aspect, it is clearly for peace of mind, and this is something which the member triggers. So just like how you have a physician who triggers or an insurer who triggers and requests for a initiates a second medical opinion, members can also say take a second medical opinion if they're going to go for a complex life-saving surgery, if they want to understand that the algorithm, the clinical pathway is aligned across all clinical experts. And regarding saving time, that was the second part of your question, right?
Yeah, like of course, like how the insurers they can standardize these triggers without impacting the turnaround time.
Health is
So we
always
already
sensitive
yes,
and
yeah.
critical. Yeah, health is always sensitive and
Mm-hmm.
critical. So something I've
Mm-hmm.
always believed in my experience, which I have put in the practical field, is a second medical
Okay.
opinion should never be your last checkpoint. It should be a process which is already embedded in your pre-authorization pathway. So the moment your trigger is highlighted from either from a cost variance, from a diagnosis variance, from a provider perspective, or if you see that there is a unjustified for the clinical diagnosis to the requested CPT for the diagnosis, and which is not supported by the past medical history, then you should trigger a second medical opinion. Every insurer should already have a second medical opinion panel, an expert panel across all disease systems. So they should either have an in-house second medical opinion, or they should have it across their network. Or and in case of more complex medical conditions, cardiac conditions, rare genetic conditions, extremely high value conditions in terms of cancer, definitely we, instead of going for an ad hoc or a firefighting second medical opinion, always driving the members to centers of excellence will ensure that there is standardization in clinical decision making. Because, for example, now we also have regulatory guidelines, because when IJADA was introduced in 2023, IJADA is now for the forerunners of reference for across all insurance and TPAs, right? Because they believed and they proved that they're more of value-based than volume-based healthcare. So this is how we can also ensure that you have an SLA, which is, if in extremely acute and complex conditions, critical conditions, it is 3 to 6 hours. And if it is an elective invasive procedure, it should be less than 48 hours SLA, which is non-negotiable.
Oh, yeah. Okay. All right. Thanks, Dr. Kruti. Okay, Dr. Sheena, in your day-to-day claims management, what are the most common scenarios where you feel a second opinion should be triggered? Like, are there any specific procedures, specialities, cost, pharmacy, or even the doctors? As you just mentioned, I think it was you or Dr. Kruti who had mentioned about the doctors also. There are some specific doctors who don't want to wait for the conservative. So, can you please elaborate on these?
Yes, Dr. Geeta. See, in a real world claims scenario, there will be triggers. Like already Dr. Kruti has said, there are different surgeries. There are procedure-based triggers. These are triggers which we should be aware of, because they are high cost. They are procedures which have a global rate of excessive use. Mainly orthopedic could be one of them, spinal surgeries, knee arthroscopic surgeries, or hysterectomy for even being done for benign conditions. Even repeated tonsillectomy, cases of tonsillectomy, adenoidectomy, sinus surgeries. So these are conditions where, based on the procedure, a trigger can be deployed. Or it could be like what was already mentioned, a cost-based triggers. For a patient who is already on a medication, if there is a sudden increase in the request being submitted for a medication, like I could quote an example of like a multiple sclerosis. We already know multiple sclerosis medications are of a high end. However, there was already a patient was already on interferon. And if the medication submitted because the patient had an intolerance to interferons, and if the patient was required to be taking a higher level of drug, which cost almost almost 200K, then definitely this is something that a second opinion has to be triggered. That is a scenario where definitely it indicates that it cannot be considered even without a second opinion. So cost base, it depends upon the policy, it depends upon the threshold, how different payers set accordingly. Then the trigger that the scenario which requires as a trigger is the clinical red flag. When the surgery recommended does not match the diagnosis or does not match the radiology, like Dr. Ravi has already said, when we feel that the imaging is overinterpreted, or if the clinical signs and the symptoms are not matching with the surgery recommended, these are scenarios when we flag them as a clinical red flag and we opt for a second opinion. Provider level, yes, provider level in hospitals who have a high turnover with high surgical rates, or surgeons mostly, yes, who have a high surgery counts, or facilities with a high admission practices, or even if there is a sudden excessive use of ICU in stable patients, These are scenarios again. Or if there is a sudden spike in surgeries in a single provider, that is one. Or in cases, or in certain hospitals, we notice that there is a high rate of cesarean sections or arthroscopic surgeries in certain specific providers. So these are scenarios where a trigger can be deployed, and these are conditions which warrant a second opinion. So this is the work of the claims team, where their flagging has to be done. They flag the providers who have an unusual pattern. So as a result, the operational benefit is that there is a prevention of an avoidable surgery, a reduction of the inflated claim, improvement in the patient safety, strengthening the medical necessity, and of course, a reduction of an abuse if it is suspected.
All right. Okay. Thank you so much, Dr. Sheena. Okay, Dr. Kruti, and now, can you share any trends or patterns where second opinions have significantly altered the treatment pathways and the cost, like what we have been discussing? We would love to hear the trends from you now.
Common trends and patterns is one is definitely there's a diagnostic mismatch which has happened, or there's a treatment modification which we see. As I've always maintained that it is like a strategic lever, right? What is the most commonest thing is oncology or in autoimmune diseases without going for topical or an oral indication. Example, in the case of multiple sclerosis, without following the step ladder approach or the IJADA guidelines, directly going for Gilenya, which is an extremely high value drug. For multiple sclerosis, where the member is in a case of remission, where the disease is stable without new lesions on the MRI, right? Directly going for Gilenya, or where the red flag or the neurological deterioration has not had an impact. I mean, for Gilenya to be justified. It has been noted that, for example, in Mayo Clinic and Cleveland, only when they go for a second opinion, only 12%, it was alarming to find out that only 12% of them came back second medical opinion with the same diagnosis. 88% of the second medical opinion came with a new or a refined diagnosis which mandated the need of a non-invasive or a conservative mode of management. The same thing when it happens in case of oncology, because oncology drives around 34% of our claims, over the last 2 years, which has been increasing. So any misdiagnosis causing an impact on claims, because misdiagnosis is one of the largest drivers of impact on our claims and policy performance, right? Next, this thing is, which I'm seeing commonly, which is mandated across all, irrespective of the network tile, which I have put across as a rule, is for elective spine surgeries. Because any cost avoidance by going for a second medical opinion through our expert panel of neurosurgeons in members who have no red flags, who have no neurological deterioration, directly going for a spinal cage with fusion or going for an arthrodesis, then going for a second medical opinion and averting this has got an impact of a claim avoidance of approximately to 150,000 dirhams. So this is some of the things which go. And second medical opinion is now with the advent of pandemic, with telemedicine and amplified use of the digital platforms in form of remote and video consultations, has actually made second medical opinion accessible through all our partners and vendors, where I have availed second medical opinions for extremely complex long-term admissions, even for Mayo Clinic and Cleveland Clinic in the United States of America. So these are the commonest triggers which we across insurers and TPAs across the insurance market is what we apply for.
Thank you. That's really wonderful to know. And especially, what I can see is nowadays it's the oncology, the immunotherapy, which really is looking forward for a second medical opinion thing. Because previously it used to be only surgery, like whether the cage is required, surgery is required. But now, because there are too many medicines which have come up, so oncology is one of those sectors where actually SMO is required and should be mandatory, could be now. Okay. Now coming to Dr. Sheena. Okay, Dr. Sheena, definitely you would have also observed some similar patterns on the operational side. We would love to hear from you too.
You mean the changes in the value of the SMO? Okay.
Correct. Yes. How they have changed the treatment pathways. Like you gave an example of cabbage, which was very interesting. Anything else?
Yes, the treatment. What I wanted to say is like a treatment pathway, like what I was mentioning about multiple sclerosis. Off my head, I could think about that. The treatment pathway was after we send that case for the second medical opinion. because the initial physician claimed that it was just because of an intolerance to interferons. However, the second medical opinion opined that it is not just because of this intolerance that this medication called Mavenclad has to be given, but because there was no changes in the radiology. The radiology did not show anything other than chronic demyelination, and
Okay.
there was no clinically there was no relapse. There was no new demyelination seen, and it is just a chronic case of continuing disease itself. So unless there is no new clinical relapse, and so because of these conditions, no neurological deficit. So because of these, the patient could be continued into the next lower level of the medication itself. So that was a case in which a high cost claim itself was not mandated, and the patient himself was sent, had to be taken up for another opinion, and in fact to the regulators as well. So we had to explain to the regulators as well regarding this condition, where of course the other guidelines came into play, and this is where there is a difference in opinion between different doctors, and we have to handle them separately. Because these different they are treated in different ways. Like that is also another scenario of second medical opinion. How to handle the different opinions, and how one part is handling the patient, and the other part for the insurer is handling of the opinions by the different doctors. So again, if it is a high value claim, the added benefit of the complexity of the medication or complexity of the surgery, for example, robotic surgeries. Why do robotic surgeries take over? Because of the added benefit, because of many improvisations in surgery. And so many patients equate robotic surgeries with being superior. So makes it increasingly difficult to guide them towards an alternative mode of management. So SMOs will work, only when there are alternate pathways. So unless there are sufficient alternate pathways, SMOs will not work. But when there are, convincing the patient is a tedious task, and then if it is possible, we will find a significant improvement, and that is when we will find that it has been successful.
All right. Okay. Thanks, Dr. Sheena. Okay. So, Dr. Ravi, like what happens many a times, when we get an MRI, it shows degeneration with disc prolapse at multiple levels. And let's say patient is symptomatic. So now from an insurer perspective, how to identify surgery is required at which level? Is it necessary to operate on all the levels, or treatment can be limited to the most relevant one? Now, for us to decide, for an insurance to decide, how can we proceed with it?
Okay, so when it is a multi-level degeneration, okay, so the symptoms that are there, the patient's sufferings that are there, whether what nerves are weak, whether the nerves at L1, L2 are weak, or L3, L4 also weak, it's based on the number of levels, the weakness that has been documented. That should be the scenario for the levels of this one. So there's an added thing is, like, suppose if the L3, L4, L4, L5 or L5S1, these three levels are stenotic and they are significant, but L2, L3 might add into the degeneration or go into an adjacent level degeneration in an recent to the recent future. So it's better to fuse them in this scenario. That's how I think that. Significantly, most of the patients who require multiple surgeries, definitely it depends upon clinical decision and their expertise. How long, what should be the length of the stabilization from L1 to S1, or should be from L3 to S1? It's completely a clinical decision. So in those cases, if that is the scenario, and if the patient is an elective surgery, you can always ask for a second opinion needs to be taken from any of the other doctors, or within the house or within in other hospital, that's also can be asked. In an emergency scenario, it's definitely not possible if the patient is having pain. So many a times I try to do an flexion extension X-ray to show what are the levels that are there. I take the photo of that, mark it on the paper, and send it to as mail so that I show the markings where the instability is there. So if that I am able to do that, then definitely the company should be able to accept it. Okay, these are the levels, and the levels that are proposed for surgery are matching with whatever the standards that are there. So that's how I try to convince my patients, insurances. So I show them this is the instability part. I take the MRI film and I take an image of that and send a mail to them if they have a query regarding why such a long surgery is required. Okay, so that's how thing is. Okay.
Okay. All right. Okay.
And just I want to add one more thing regarding the requirement that has been coming regarding the second medical opinion. So we need to follow certain red flags as such, which are like you can make the second medical opinion mandatory if it is a complex surgery. So instead of using L3, L4, if the person is going to D10, like from the thoracic level to the lumbar level. Okay, so if the complexity of the surgery is increasing for a level which is not related, and if it is a non-emergency immediate surgeries, like elective surgeries, definitely second medical opinion might benefit. Always the company can ask from the patient or from the doctor to have a second medical opinion. And unjustified advanced techniques, so where a minimally invasive surgeries are demanded always, or in open surgeries are not this one. So though the rate of clinical the results that are there in the minimally invasive as well as in the open surgeries, they remain the same. The number of adjacent level diseases or the number of hospital stay in both the things are same, but the cost of the implants almost is double when it comes to minimally invasive things. So they needs to be justified on whom they are operating, on what level of the patient, what is the age of the patient. They all needs to be this one accordingly, whether those advanced techniques are acceptable or not. Okay, so when the symptoms are the proposed surgeries, they are not matching, it's always to ask for the second medical opinion from the company side. Okay.
Okay, all right. Thank you so much, doctor. Okay, as Dr. Kruti had mentioned about the turnaround times, because of course they're mandated by DHA. So, Dr. Sheena, how can insurers balance these TATs, a fast claims processing, with the need for the detailed second medical opinion? And what operational models or best practices have worked effectively to maintain the turnaround times while we are taking the second medical opinions? Dr. Sheena, you are on mute.
Mute, yeah, please.
Yes. Second medical opinions, they are a critical safeguard. However, unless they are effectively deployed intelligently into a day-to-day claims workload, they will not be very much benefited. So there are many operational models, but then I would say the most globally accepted model is categorizing the claims into low, medium, or high. This will let us know which case has to be taken up for an SMO. Most common is almost I would say 60 to 80% of the claims fall into the low risk category of claims, where they are guidelines aligned, and so SMO is not really required. While the medium risk of the claims, they are claims where the claims adjudicator finds out if there is a red flag. That is when a claim becomes a medium risk. However, a claim becomes a high risk according to the procedure, according to the cost, according to the provider. So these are the models. These are the operation models that will decide whether a claim has to undergo an SMO or not. Now, for this, there are different practices that can be deployed. Of course, the most common practice is having a dedicated SMO panel, having a steady flow of specialists within the panel, an orthopedics, definitely a spine surgeon, OB-GYN, a physiotherapist in the panel who will respond to a prompt SLA of 24 to 48 hours for elective surgeries, and of course for emergency surgeries within a couple of hours. That is mandatory. And having a standardized template so that the communication is clear. Having clear and transparent communication is the way to sort out the problem, because many a times the second medical opinion is not what delays it. The delay is always in the communication. So the having a clear communication with the provider, having a clear communication with the member is what is mandatory, is what is necessary. And then lastly, it is important to track, the feedback is required to track the response from the provider. That will avoid high risk, because a clear explanation to the provider after the SMO is received, after the second opinion is received, a clear explanation has to be given to the initial physician as to why you are maintaining your denial, as to why the initial surgery is not indicated, why we are opting for, why we prefer or we are giving an alternative surgery. That has to be written, that has to be documented to avoid the legal implications of the surgery, of the request. So if we have such a program in view, if in place, then of course if the panel should be able to take care of it, and if that is the case, then that should be a smooth flow of an SMO on a regular basis.
This sounds really interesting to have a panel on board for second medical opinion. Definitely is going to, it's really, really interesting. Yeah. Okay, Dr. Kruti, are you seeing any emerging trends across the industry in terms of adoption of second opinions? Especially when we all know that digital health and telemedicine is so much into practice now. Any data points or insights from your tenure that highlight its growing importance?
As much as digital platforms are completely optimized and they are being used by all the leading insurers, with the advent of AI taking over our lives, I see that we could use that as a system also, but a lot of integration and back-end work is needed for that. I would like to emphasize once again that AI will not do the job what a clinician or a specialist does, because it will definitely miss the touch. But then AI can be used in terms of scalability, in terms of standardization, it can be used, because they can only act as a flag. They can flag based on any irregular patterns, on based on cost, whatever rule-based engines you can give based on any trajectories in terms of provider behavior. They could use, or if they see certain unjustifiable this thing based on costing rules that has been put, or this thing, they could flag those cases for second medical opinions. I think that's my this thing on the new trends.
Excellent. Thank you so much, Dr. Kruti. Thank you so much. Okay, that was really a rich and thought-provoking discussion. And I really thank all of you for that. If there's one idea to leave with today, it's second medical opinions are not about questioning decisions. They are about strengthening them. They sit at a very powerful, smarter decision. And as we have heard today, when used well, they don't just reduce the cost, they improve confidence, clarity, and outcomes. Thank you once again to all the panelists and all the audience over here. And now it's over to you, Ankit, for question and answers if the audience may have any.
Thank you, Dr. Geeta. Thank you, Dr. Sheena, Dr. Kruti, and Dr. Ravi for the insightful discussion. Actually, we'll take some little more time of yours, actually, because we have a couple of questions coming in. I will quickly open the chat forum now, and everybody in the audience are most welcome to ask questions. I would request it to direct to the doctor you want to ask to, so that we are specific and we don't waste much time. So in the chat forum, you can start putting up the questions. I already have one question with me. I'll just quickly put it on the chat group so that everybody can read it, and then we can take further. So I think it belongs to the payer side. So probably Dr. Sheena or Dr. Kruti can take it up. I will read it out. It is from Dr. Arjun. He's the claims manager at Fidelity Insurance. So I'll read out the questions for everybody. In oncology and other high-risk conditions requiring multidisciplinary review, how should a payer define the right trigger for second medical opinion, particularly where treatment justification may be argued under different guideline frameworks such as ASCO or NCCN, where both are cited? How should the payer operationally decide which standard to rely on for medical necessity and cost governance? Probably Dr. Sheena and Dr. Priti, you can both take it up one by one. So Dr. Priti, if you would like to start and answer, and Dr. Sheena can continue. I have
Thank
put
you,
it in the
Dr.
chat section if you want to read. Yeah.
Thank you, Dr. Arjun. Yes, oncology is quite an epidemic of that. We're able to see that so there we have seen that there's been a spike from around, it was 23% to 34% in 2024 to currently we have 47% of our claims to be driven by oncology claims now that it is an epidemic. So towards when it comes to second medical opinion, of course, for us, our standardized guidelines is what we go is for NCCN. But however, it is also important for us to go for a second medical opinion when it comes to chemo regimens, which is there. That is what we are able to see is the impact. There are two things why second medical opinion is should go. One is which are the cases which can go first for surgical, followed by neoadjuvant chemo and radiotherapy, or those cases which are actually inoperable based on their HP reports, based on the organs that the metastasis have taken in cases which are inaccessible for surgery, right? As cancer claims can drive and exhaust the member's limit. Second medical opinion in most of the cases are mandatory so as to ensure that there is better policy viability and for the benefit of the member so that he is able to use his policy annual benefit limit through his policy period. Directly going for immunotherapy when you're having alternate chemo regimens which have equal efficacy, clinical potency, clinical efficacy in terms of their targeted mode of treatment. If you could go for the step ladder approach as guided by NCCN instead of directly going for immunotherapy, which could burn not only the policy but also exhaust the members' limit. That is where second medical opinion will help in terms of both in terms of cost governance and medical necessity.
Great. Thank you, Dr. Kruti. And Dr. Sheena, would you like to add on something from your point of view? Yeah.
See, when there are different pathways and different guidelines for the same diagnosis, which are internationally accepted, so which cannot be questioned because both the doctors are probably right. It is a gray area because in such cases when a second opinion is taken, that would be a third guideline again. So all of them would be equally. One must be a European guideline, one must be an NCCN guideline. So it is all recommended. So it cannot be that it is not. It is going against any medical guideline, and it cannot be approved or it can be denied. So in such cases, we need to take the stand of the patient. What is the patient's policy going by? How much of a limit does the patient have? The patient's safety. What is he comfortable with? Will he agree to take it at a facility which will control his policy better? So these are the conditions. These are the queries which has to be taken up further when the medical part of it, the guidelines part of it, is all supporting it together. When there is no way that any of the doctors are to be blamed, or when there is no doubt on a medical necessity here. When in such cases that takes a back seat. So in such cases, the patient safety, the policies control, that has to be taken into the forefront, and again further discussions, and of course a discussion with the doctors as well to decide on what is the best mode of treatment. So that is when the doctors will definitely go in and take a decision on themselves on if they opt for a safer mode or another less invasive maybe a method would be opted for. If they find out maybe if the patient's limit is minimal, or if they cannot offer, if their limit of pharmacy is very little, then the doctors themselves will opt for the lesser invasive method of treatment. Hope that answers your query, Dr. Arjun.
Thank you. I hope it does. Dr. Sheena, thank you so much. Another very quickly, Sri is asking, a good session. Thank you, Sri. However, my question is, when SMO is not a part in your TOB, table of benefits, how do you still offer and cover the service? It has two parts, so probably Dr. Kruti can take the first part. If it is not there in your table of benefits, how do you cover it? How do you manage the situation?
Shri, good afternoon to you. The primary role of any insurer is to ensure that patient efficacy, patient safety is also taken care of. So SMO is, it may not be, as far as I know, all TOBs are right across the platform, unless it's a very, very basic platform, offers an SMO as second medical opinion, because it is the right of the insurer and it is the right of the patient. Second medical opinion is an insurance tool, which is not only for better patient outcome, as I mentioned to you, it also to ensure the quality control mechanism and to also identify fraudulent wastage purposes. When you are sure as an insurer, as a clinician, that this needs a second medical opinion, as an insurer, considering the impact a second medical opinion, especially when you're sure that it is not aligned with the clinical pathway or the clinical advised surgery is not aligned with the past history and with the clinical documentation. As an insurer, it is your right to offer the member in your own expert panel in lines with the members network eligibility to send them at the cost of the insurer to send the member for a second medical opinion, because if you know that it has a positive impact on how the claims will perform, it is for better patient safety, better patient peace of mind. It is something which is a cost which the insurer should bear. And regarding the opinion which takes place, as second medical opinion is a tool which is given basically for elective procedures, so it is not as important, or it's not so fast as it in terms of acute or emergency conditions. So second medical opinion, you could do it in two ways. If the member refuses, suppose you have a very high-end member, it's a very elementary and a practical problem. You have a member who's a VVIP who would say, I do not want second medical opinion, but you know that the patient needs it, this particular patient needs it, you go for a second second medical opinion. You could also offer it through as in form of telemedicine or digital platform using the video consultations. Otherwise, for us, it is the second medical opinion should not, I personally feel, should not exceed a turnaround time of 48 hours. That is including consultation and including reporting back to the insurer.
Yes, agreed. Dr. Kriti, thank you. I will take another question for you, Dr. Shina, because we have so many questions coming up for insurance. There's one question which says, Dhruv is asking, how should insurers handle situations where treating doctors disagree with the second opinions? And what is the best approach to ensure collaboration without damaging provider relationships?
Yes, that's a very sensitive. It's a very sensitive method, because the whole burden lies on how the insurers handle the delicate situation. Not agreeing to the peers' mode of management is a common thing in clinical medicine. However, how the insurer handles it is it's very delicate. It's very sensitive, because firstly, like I think I've already mentioned it. Firstly, how we convince the member of going forward with the second opinion doctor's mode of management is one part of the claims adjudication or the pre-authorization team's management itself. Second part is convincing the initial treatment physician itself of the denial of the reason for why his treatment is not going to be approved. So we cannot be blatantly denying it or disagreeing to his price. So what can be done is either a peer-to-peer conversation can be agreed upon, in which case the doctors can agree mutually on a common mode of treatment, a common platform of treatment can be agreed upon, or what I think is an alternative method of treatment can be approved. Like, for example, if it's a spinal surgery that a second opinion doctor has not agreed upon, according to his opinion, it is not indicated. Well, in that case, there are sometimes that most of the cases the patients do not want to continue with that conservative management or do not wants to go back to the initial doctor itself. So in such case, what do? What we can offer is request the initial doctor to please continue with an initial conservative treatment. And if that does not improve, then you can proceed with the spinal surgery. So give a clause, give an alternative treatment, and provide a clause to which the initial management would be give an option, and then proceed with the initial treatment, with the second opinion management, if at all it is recommended. So if that is the case, you will sort of balance it, and at the same time you will maintain the relationship with the providers, because that is important in continuing your stay in this industry, and also to maintain the patient's relationship, and also the patient, and also for the patient's safety aspect. And in case and in su- in there and in case there's a scenario where it does not in this does not benefit at all, we have the regulators to go out to reach out to. There are regulatory guidelines which support, like the guidelines are there where we can go to for which is a third body again, where who has given their specific guidelines. That is something that will be referred to, or the regulators will take a call on the best mode of practice.
All right, Dr. Sheena, thank you so much. And I'll just quickly take one more question. I mean, we have more questions as well, but this comes from my our CEO, Mr. Amit Sharma, and this is for Dr. Ravi. So, Dr. Ravi, from a clinical standpoint, how do you see the role of AI in supporting medical second opinions, particularly in complex cases like orthopedics and spine disorders? Would you like to answer this one first? Do you believe AI can reliably assist in interpreting radiology findings or correlating them with clinical symptoms to guide the treatment? So there are two parts to it. So first, you can answer this one. Yeah.
Yeah, I'll start with the first one.
Yeah.
As such, none of the medical books are like, we follow certain medical ethics, right? So AI is not yet accepted as an advisor for a medical treatment part. Okay, so definitely the question of AI doesn't arise. Okay, so as such, since there is an second medical opinion is possible, so we need to establish an kind of the communications and the turnaround time for the second medical opinion. So that should be the better option instead of depending upon the AI. Regarding this, the second question, uh, definitely whatever the AI, like if I suppose a disc problem of so and so, like around 50% disc bulge and compromising the canal for 50% becomes a medical indication, whereas clinically it may not be the scenario. Okay, so if I say the canal size of 50% is an absolute indication for surgical intervention, which most of the time, most of the patients will be symptomless. So the AI might over-treat a scenario. That possibility is also there. Uh, as a support tool, still it's developing. You can always keep it as a support tool, and in future, if AI is able to pick a better option or a better opinion under this one, so can definitely be considered. But as of now, it's better not to depend upon the AI for the decision making part of the treatment. Okay.
All right. All right.
So
Dr.
another
Ravi,
thing
thank
that
you.
I'll just add one more thing. Suppose if I have a patient who is 80-year-old, and definitely one in like one in million may not like be as a candidate for a surgically. So still, if I say like the if I AI picks that as a patient for surgical indication, so definitely we are on the cost of that thing will also increase, and the selection wise also it may not be acceptable for doing it. Okay, so tomorrow every 80-year-old patient will come and demand for a surgery if it says. Okay.
All right, Dr. Ravi. Thank you so much for your answer. And since we are discussing about AI, Dr. Kruti, I would like to ask a similar question to you, given your extensive experience across both clinical and insurance domains and your work in streamlining claim process. How do you see the role of AI in enabling and scaling medical second opinion frameworks? We have two parts to it. So would you like me to read the first part so that you can relate? Yeah. Do you believe AI-driven recommendations can reach a level of clinical reliability and consistency that insurers can confidently depend on?
See, AI will never be able to take a clinical decision like how us, a consultant with a clinical acumen, with like Dr. Ravi will take, and an AI should never be allowed to override a clinical decision making, because one thing which is non-negotiable here is touch, and it is about the clinical examination, red flags, identification of it, physical auscultatory examinations, and everything. So an AI should never be allowed to override and dominate a specialist review. AI only works on based on the principles of like NLP or machine learning or something. So AI will only be able to assist you to bring about a scalability and stability and standardization across decision making through early detection, and based on what rules you feed it, what triggers you feed it to recognize patterns between when you put a trigger in the form of to flag a case based on a cost of it, or based on any discrepancy between the ICD coding and abnormal escalation of claims, reduce the manual workload. So only based on these, AI will be able to assist and probably augment, but it should never and will never be able to replace a clinical judgment, because best practice methods will always dominate when it comes to clinical adjudication.
All right, fair enough. And just a second part of this question is, and from an industry standpoint, do you see insurers being open to adopting and accepting AI-supported second medical opinions as a part of their claim decision making?
See, as
I mean,
insurers,
yeah.
we already have AI because our highly dynamic automated system rule adjudication are already in process when it comes to our claims adjudication and comes to data driven studies, because that's how we're able to flag clinicians based on data mining at a granular level. So AI is already in places, but only different levels of complexity and different levels of maturity as exactly what is fed by the clinical governance of each organization. So that is something which is already in place. And definitely considering the volume of claims, considering to ensure turnaround times, to ensure maintenance of SLAs, to ensure that customer satisfaction is never compromised, and also to highlight clinicians who are having fraudulent practices to ensure policy viability. I definitely think that AI will absolutely add as a supporting tool uh, in assisting and flagging cases which need second medical opinions. And I would like to once again reiterate that it will never ever, and it should not override clinical decision making or override the decision of a treating physician.
All right, all right. Well said, Dr. Kruti, and thank you so much. We have Mr. Abbas Alam from Leva, who is the provider and TPA lead, provider governance and TPA lead. He has a question. So he asked, what change PD05 brings to the case management process, and how is insurance companies adopting to it? So probably Dr. Sheena, Dr. Kruti, if you guys can take this up. PD05, that's a
What was
It's a
that
policy
again?
directive.
by DHA.
It's a
Policy.
policy directive by Deshad, and I would
Yeah.
like to hear Abbas's take on it, because Abbas'
Yeah.
brainchild is case management of Sukun. So I would like to know, and Abbas has been a very cherished colleague of mine. So I would like to know, because and the case management is the brainchild of Abbas, and how seamlessly has handled it is, I think we all know, as partners and as colleagues. So I would like to know, and of course, case management is something which is a mandate, considering the PD05 itself, and considering how the based on the annual benefit limit, it is extremely important for us to ensure that there is cost optimization. So I would like to hear Abbas's take as what has changed when he changed and when he started case management to now with respect to PD05. I'm sure
Mr.
I hope
Alam,
everyone else wants to hear his take, because
absolutely, absolutely. And I'm just connecting with my IT. If he can open his mic and he's able to speak, because we have limited IT restrictions. But of course,
okay.
let us see if he can join. It's a surprise speaker, Mr. Alam. Yeah. Okay. Till the time we
Case
do that, yeah.
Case management
Till,
has been a tool, just like second medical opinion. Case management has been a tool, whether it is in terms of costing second medical opinions, asking for appreciable package prices, negotiation at contractual levels, and also using the home country benefit. So that has been a continuous case management process which we have always kept in place. And considering our members, who we need to connect, and we need to ensure that they have coverage over the entire policy period, definitely case management continues to be the most driven aspect across all insurance companies, all TPAs, to ensure that all the policies perform with an appreciable LLR, because otherwise it will have an impact on retentions, it will have an impact on renewals and all those things.
nice.
Abbas,
I've
would you like
put
to add
Mr.
anything?
Alam on frame. Yeah, I could fight him actually. Let me.
No worries.
Can you
Thank
disable?
you,
Yeah,
everyone.
I can hear you.
This is surprise. I was never part of speaker group. I'm so elated. Thank you, Dr. Kruti and Dr. Geeta and Ankit and Nancy. This is I'm not prepared for this, but just to give this insight, because I had this question in my mind during all the time this we are discussing, and this might not be the right forum to discuss PD05's limitations or limitation it is causing us. But then still, since we are discussing case management and SMOs, these are basically time driven with time limitations kind of activities, which has dual impact on insurance as well as on the members, because insurance cannot take their sweet time and then reply and arrange SMOs and treatments, because it's a member's life at stake most of the time in most of the emergency and elective cases. Now, what change this PD05 brings is that now we do not have to act like the one which we were doing before. We have to act like a gatekeeper. Case managers have to act like a gatekeeper, that we have to coordinate everything from in and out, from starting to end, and make sure that the regulatory guidelines are met, as well as members' experience are not spoiled. So the need for SMO or a quick SMO is now more apparent after this PD05. PD05, for those who are not aware or not part of UAE market, it's a policy directive which has come across in November 2025, which is now forcing insurances to close cases at a very tight schedule timeline. Earlier, before, it was more relaxed. So yeah, this is my take. I just wanted to know how these pioneers have structured their organization. So just to learn and understand again from Dr. Kruti about how her take is on those things.
Thank you, Mr. Alam. Dr. Kruti, you're on mute. You would like to say something? Yeah.
Yeah, see, as per any policy directive, which actually started for in case of emergency cases from 2016, actually, whenever it comes as an emergency, the amount of abuse which you see is less, because it is more about clinical stabilization from life-threatening emergency. Your second medical opinion, the only driving cost could be the cost and the weight of the DRG, could be the cost of the life-saving procedure which could be done. So the percentage of abuse in that is minimal. However, for members with unjustified length of stays, clinical course of history, and the complexity of care remains critical with no clinical improvement, that definitely mandates case management in the form of audit and case and other things. But otherwise, in case of elective cases, the standard is second medical opinion, the case management team, negotiations, and all that will follow.
Great. Thank you so much. And thank you so much, Mr. Alam, for a surprise visit. It was indeed a surprise for all of us, and thank you for joining us. Okay, so with this, I think we are getting more questions, but we are already ahead of time. We are closing almost to 2 hours now, which is great because, a lot of questions coming in, a lot of discussions happening. So I would have taken more questions, but due to lack of time, we come to an end. So thank you to all our panelists for the insightful discussions, and to our audience for joining us today. A big thank you as well for the entire team of Prospera who is behind this session. We truly appreciate your support as well. We'll be sharing a feedback link shortly. We would love to hear your thoughts. So all the registered audiences will get a feedback link. You will also receive a YouTube link soon so that you can watch the webinar again and share it with your friends and colleagues. That's it. We'll be back with another engaging webinar, so stay tuned. Do you have any thoughts? Last moment, Dr. Kruti, we can start with you, and then Dr. Sheena, and then Dr. Ravi. A last thought? Yeah.
It's extremely just a note of gratitude and appreciation to the entire team of Prospera, to Amit, Ankit, Dr. Geeta, and Nancy, and the entire team, the technical team, and who worked back in, because it truly was a stimulating discussion with the industry experts and with our phenomenal audience. So thank you to everyone who joined and participated in, and looking forward to more such webinars from Prospera team. Always such a privilege to partner with you all.
Thank you so much. Dr. Sheena? Yeah.
Yes, thank you. The entire Prospera team, Dr. Geeta especially, Nancy, Namit again, hoping to catch up again on all our conversations, regular conversations. Yes, it's been a delight to be here in the audience, and to be to listening to everyone, all pioneers in this field, of course. So thank you, and looking forward to more sessions. I could think of many more topics on second medical opinions that we haven't discussed. And yes, this 1 hour is not enough because we could go into branch out into different topics again. So yes,
Absolutely, yeah.
for what we have discussed, it was very informative, very delightful. And thank you, Dr. Ravi Kumar as well, Dr. Kruti. Thank you. Always a delight to hear from you. Thank you,
Probably
Dr.
we can have
Geeta.
a series 2 of
Another
SM
session.
as well.
Part two
Yeah.
of it.
Yeah.
Dr. Ravi,
Thank you.
last thought, and then
Yeah.
we will end. Yeah.
Yeah, thank you. Thank you for the Prospera team for having me here. But one thing is, this is an eye opener for me because I always sit on the other side of you people.
Yeah.
So definitely, this gives me a chance to like learn what the company is demanding or how they are feeling, whether the decision making of ours are correct or not. So this is very good for me because this will, with this, I will be able to improve the thing with my team as well through our department also, so we can make things more easier for the patient's perspective. At the end, they are the one who are the receivers of both the benefits, both ours as well as yours benefit. And definitely I will be happy to be a part of any of your next events like this.
Absolutely.
Thank you.
Our pleasure,
Thank you.
Dr. Ravi. Thank you so much. And
Thank
good
you.
that you mentioned
Thank you,
that,
Dr. Ravi. Thank you so much.
Since we work very closely with insurance and providers, it's good to have such sessions so that we can, bring all together and have each other's insights and everything.
Definitely.
All right.
Definitely.
That's it.
Okay.
Have a safe weekend, guys. Thank you so
Thank
much,
you, everyone.
everyone.
Thank you so
Once
much.
again.
Thank you.
Thank you so
Thanks a
much.
lot. Have a lovely
everyone,
weekend. Thank you,
again.
Dr.
Thank
Geeta.
you.
Thank you, Nancy.
Bye.
Bye-bye.
Thanks.
you.
Bye. Bye.
Hello, Sidhu.